it's given as 1, and it's just an introductory, so there aren't very many details. But if there are any questions, you can write them down, or if you need me to clarify something, you can always raise your hand, and so that I clarify as we go along. So for the first part, we are just going to look at introduction, the causes for upper airway obstruction. We will briefly look at how you evaluate a patient who has upper airway obstruction and come to a diagnosis and just an overview on the management. So first, we need to understand what is the upper airway, because sometimes you get obstruction even lower down in the airway, but that's not in our area. For ENT, we deal with the upper airway. So the upper airway consists of the area from the nose up to the upper trachea. Although for us, we actually go down even into the bronchus when we have an obstruction there. So now in the airway, the upper airway, you can have obstruction at different levels. One could be at the nose, the level of the nose, and then inside the nasal cavity. As you go back, you will get to the pharynx, which consists of 3 parts: the nasopharynx, the one related to the nasal cavity or the choana, and then there's also the oropharynx related to the oral cavity, and below that, the hypopharynx related to the larynx, also called laryngopharynx. And again, we have the oral cavity itself. And then below the hypopharynx, let me use my pointer. Then we have the larynx, and below the larynx, the trachea. So what can cause obstruction at all those areas? The best way is to look at groups of conditions that can cause obstruction. I'm looking at this for the area above the larynx, then the area at the larynx and below the larynx. So I've put them into groups: congenital causes, infectious causes, traumatic, tumors, and then others that I couldn't quite fit in any of the groups. So among the congenital ones, one at the level of the oropharynx and oral cavity, you could have micrognathia. That is a small, some syndromes that come with a small mandible, which then pushes the tongue, the base of tongue posteriorly and makes the airway small. Macroglossia, that's an extremely large tongue, which would prolapse backwards and cause obstruction. Choanal is a condition where during development, the posterior aspect of the nose does not canalize. So you find that instead of that tissue there that would have broken down during development of the nose and the oropharynx, that tissue persists. So you find that the nasal cavity is open, but there's no opening between the nasal cavity and the nasopharynx. And that comes with other malformations. Then you could have a lingual thyroid. We all know from our anatomy that the thyroid develops from the base of the tongue and goes downwards, descends downwards. If that descent fails, the thyroid remains in the area of the base of tongue. And as it grows, it may cause obstruction at that level. In the nose itself, you may have septal deformities like a severely deviated nasal septal deformity can block the nose. And then sometimes you could also have arynia. Arynia is a situation where the nose doesn't develop at all. So these children are born with no nose and can only breathe through the mouth. Among infections, I have a few examples. Abscesses like a retropharyngeal abscess. That's an abscess in the posterior part of the throat. Pediatric infections like diphtheria, infectious mononucleosis. All this can cause obstruction. And then you can have trauma, like during an accident, facial fractures. Somebody can get burnt and have a lot of edema in the airway and get obstructed, or a hematoma that expands and blocks the airway, or just edema from any other problems, even drug reaction. Among the tumors above the larynx is the commonest is a nasopharyngeal carcinoma, which is in the nasopharynx, and it can grow down all the way into the oropharynx. Juvenile angiofibroma in the sinuses, sinonasal tumors that are growing posteriorly, and in the mouth, oral cavity and oropharyngeal cavity. You could have squamous cell carcinoma of the tongue, or of the buccal cavity, or of the tonsils, causing obstruction at that level. And then among the others, we all know about adenoids and tonsils that hypertrophy in children, causing them to snore and have difficulties in breathing. Myxedema is this is a situation where one can react to maybe a drug or a chemical and get very severe edema. And people who are obese tend to also experience some amount of obstruction at the level of the oropharynx, because all the structures there tend to reduce the airway, and especially when they sleep, then the relaxation of the tissues narrow the airway. Allergic rhinitis is an allergic condition affecting the nose, and that results in large turbinates in the nose, which block the nose and cause obstruction. And in rare situations, granulomatous diseases of the nose also cause obstruction. At the level of the larynx, again, we have them, the conditions grouped in the same classes, congenital, infectious, but now we introduce neurological, and then trauma, tumors, and others. So congenital conditions in the larynx include laryngomalacia, which is common. We get children sent to us who have an inspiratory stridor. Whenever they draw in air, there is some noise. And when this is severe, they also experience breathing problems. At the level of the vocal cord, you may find a web at the anterior aspect, narrowing the airway and therefore causing obstruction. And in some situations, the larynx fails to canalize so that there's no airway there. But stenosis or atresia is not compatible with life. Then we can have vocal cord paralysis that is congenital. And when the vocal cords are paralyzed and in the midline position, then there is airway obstruction. And occasionally you get a stenosis below the glottis, which we call subglottic stenosis. Among the infectious conditions, epiglottitis, this is an inflammatory infective condition of the epiglottis. So the epiglottis swells up and obstructs the airway. And then commonly in children, we have heard about LTB, laryngotracheobronchitis. And even in adults, we get tuberculosis of the larynx, where the tuberculous lesions are actually just big like tumors and causing obstruction. And apart from vocal cord paralysis arising from, being congenital, you can have vocal cord paralysis resulting from, say, surgery of the thyroid or any other surgery in the neck, or masses that are in the mediastinum, where the recurrent laryngeal nerve goes before it comes back into, to innervate the vocal cord muscles. And you can also have a general muscular paralysis that can result in airway obstruction. Among the traumatic lesions would be like intubation. During intubation, you can traumatize the airway, the larynx, and get obstruction. But again, if somebody gets intubated for a long time, the pressure of the cuff of the tube or the end of the tube that was used during intubation can cause edema and cause sometimes granulomas, which result in obstruction. Fractures, as in the case where you have external injury or external trauma to the neck, resulting in the fracture of the cartilages that form the larynx. And then foreign bodies, this is more so in children who tend to maybe swallow. Commonly we see vegetative material like beans, peanuts, but also metallic substances. You could also have subglottic stenosis resulting from trauma, especially intubation trauma. And I mentioned thyroid surgery. Then tumors of the larynx, the common ones are carcinoma, and tumors in the hypopharynx and thyroid can also spread into the larynx and cause obstruction. And in the thyroid, it can also cause just direct pressure. In children, we get benign lesions caused by HPV called respiratory papillomatosis. These are just papillomatous lesions that grow in the upper airway and cause obstruction. And just below the glottis, again, where occasionally you get congenital hemangiomas in children. Adults, very rare, but yes, you could still find hemangiomas in an adult in the subglottis. And then among the others are sarcoidosis, angioedema, just edema in that area, especially in smokers, and granulomatous diseases as well. In the trachea, again, we have the same classes. You could have congenital lesions like tracheomalacia. You could have vascular rings, that is abnormalities in the development of the vascular tissues, which then form a ring around the trachea and compress the airway. You could have infections like tracheitis, which can be isolated or a part of LTB. You could have trauma from intubation or from foreign body or from external in the neck. You could have primary tumors in the trachea, which are rare, or you could have tumors spreading from the esophagus or thyroid into the trachea. And like you said, external compression from goiter, cystic hygroma, and any other masses in the neck. I have just put here a few examples. Now, this is a massive cystic hygroma. Actually, this baby was born in KNH. With this mass, which is a cystic hygroma. It's a lymphatic congenital malformation. Here we have a thyroid, which can cause, a thyroid mass, which can cause obstruction. And here, these are the vocal cords in the larynx. And there is a mass here, a tumor. Here, the child has a huge tongue, looks like perhaps a vascular lesion. And this is what we see in laryngomalacia, where the epiglottis is omega shaped. Omega is this kind of shape. And so when it's like this, when the child draws in air, these ends just collapse in and block the airway, so the child cannot breathe. And this is arynia. Actually, we had a child last month who was also born without the nose. And under such circumstances, you know, because children are obligate nasal breathers, you have to put something on the mouth, an airway, and strap it there to keep the mouth open, because they don't know how to breathe through the mouth. They have to learn it slowly. But eventually for this kind, we would have to do we actually did a tracheostomy on that child. And this is an example of a vascular ring. You have this vessel compressing. Actually, here it's compressing the bronchus, not really the trachea. This was also a patient we had who had an AV arteriovenous malformation of the tongue that was causing obstruction. Here is a foreign body, a bone, in the at the level of the vocal cords. And here, the anterior aspect of these vocal cords, you can see there is scarring and it is fused. That is a laryngeal web. So how do you approach management of an upper airway obstruction? First, you want to evaluate the airway, the severity and stability, because this will guide you in knowing whether you want to do any investigations first, or you just want to create an alternative airway in this patient. And then acute versus chronic. Chronic ones tend to be slower. You know, they have been developing over time, and the patient has sort of learned how to compensate. Acute ones are very serious. You want to take action as soon as is possible. And then you listen to the sounds that accompany the respiratory movements. I'll define this, whether it is a stutter or stridor or it's just dyspnea alone. And once you've evaluated the airway, if you think you must establish an airway, you go ahead and do so. So how do you establish an airway? You can use an oral, depending on where the obstruction is. Like if it's the nose that is blocked, or that baby I mentioned with arynia, or choanal atresia, you can actually put an airway in, the ones that anesthetists use, and you strap it with the strapping on the upper and lower lip, and they continue breathing. So you bypass the obstruction that would be in the nose or in the nasopharynx. If the nose is patent and say maybe the obstruction is on the tongue here anteriorly, there is an nasopharyngeal airway which you can push through the nose, and it hangs here. This will bypass an obstruction in the oral cavity, and the patient can continue breathing before you find a permanent solution. If that is not possible, you can intubate the patient if that is feasible. A third option is to do, if you cannot intubate the patient, say obstruction is up here and the endotracheal tube cannot pass, you can do what is called a cricothyrotomy. A cricothyrotomy is an incision you make in the cricothyroid membrane. There's a cricoid thyroid here, and at this point there is the thyroid cartilage. So between the thyroid cartilage and cricoid cartilage, there's a cricothyroid membrane. So you feel for the two cartilages, and that space in between, you can easily make an incision there and push in a small tube to allow the patient to be breathing as you look for an alternative airway. And then we have a tracheostomy. We look at how that is done. And once you've established the airway, then you can administer oxygen through that airway. After you are sure that the patient has a good airway, then you want to go into the history. But if the patient was stable and you have to take a full history, you can go ahead and take. And so you want to look at the character of the upper airway sounds, like we talked about it. Stridor is that sound that you get when the airway is blocked from the level of the larynx downwards. Stutter is the sound you get when it is above the larynx. Then there is snoring versus a wheeze. Snoring is again above the larynx. A wheeze is more in the lower airway. And you have phases of stridor. It can be inspiratory, it can be expiratory, or biphasic. Biphasic meaning it is accompanying both inspiration and expiration. And when you pick this, then it tells you about the level of obstruction. I have that coming in the next slide. Then you want to take a history on the onset and duration of the obstruction, whether it's constant or it's intermittent, and whether there are any contributing factors. And then associated symptoms, like if there's dysphagia, then you're thinking perhaps the digestive tract is also affected, and you're thinking, where could this be? Either at the level of the laryngopharynx or pharynx. If they are drooling, you are thinking the obstruction is relatively high because saliva is not going down. If there is hoarseness, you know that the vocal cords must be involved, because vocal cords are the ones that produce voice. If there's weight loss, you are thinking, is it a malignancy? When it is snoring, you know that it's the upper, it is maybe the level of the nose or the pharynx. If they are choking as well, you are looking at something just near the larynx. And then you also ask about trauma or any other relevant history. So description of the upper airway sounds. When the obstruction is at the level of the nasopharynx, you get stutter or snoring, but there is usually no cough. Stutter is the sound that you get when the nose is blocked and the person is awake. When they are asleep, it is snoring, but when they are awake, it is a stutter. When the obstruction is at the level of the oropharynx, the breath sounds are more gargly, like something gargling, like when you gargle water. When it is at the level of the supraglottis, that's above the glottis, but within the larynx, the stridor, that sound that accompanies the respiration is inspiratory. It accompanies the inspiration, but the expiration doesn't have a sound. And the voice tends to be, the voice is throaty, and the patient will also have feeding problems because at the supraglottis, you are just next to the digestive tract as well. At the level of the glottis, like we said, because the vocal cords are responsible for voice production, you'll get hoarseness, and the stridor will be both either inspiratory or biphasic, meaning both inspiratory and expiratory. When it is at the subglottic level, it will be biphasic. And if there is a cough, it will be barking. And below that, in the tracheobronchial tree, you get expiratory stridor, and there might be a wheeze if you listen carefully. And you also observe suprasternal recessions. So when you clearly consider this, you can be able to guess at what level the obstruction is. And this is important because, if you miss the level of obstruction, say that it is very low in the trachea, even if you did the tracheostomy, it will not, you will not bypass the obstruction, and so the patient will remain obstructed. Then you go on to physical examination. You want to examine the nose, the oral cavity, the neck, the chest, and not just for the respiratory sounds, but for the heart sounds as well, because we know that cardiac problems can also cause difficulties in breathing. You want to do a neurological examination because it could be related to neurological issues of the vocal cords. And then you do the rest of the ENT and systemic exam. And an indirect laryngoscopy is advised except in a patient who has epiglottitis. Because if you touch the epiglottis and they have epiglottitis, the whole area goes into spasm and they will obstruct completely and perhaps pass on. An indirect laryngoscopy is a mirror examination where you have a laryngeal mirror, and remember you have lights on your head, you have a light source on your, a light, yes, something that is giving you light from your one on your head, if you've ever been to the ENT clinic. So you direct the light onto the mirror in there while you're holding the tongue and keeping the mouth open. And before this, you have anesthetized the throat with an anesthetic spray, lignocaine most of the times. So when you put that mirror and look into the mirror, you shine the light onto the mirror, you will see the structures down reflected in the mirror. And that is why it's called an indirect laryngoscopy, because you are not looking at the structures directly, but their mirror image. This is a clinic procedure. We do it in the clinic, except COVID has stopped us from doing it now. Then the other option you can do to look at the airway is use a fiber optics nasoendoscope. It's a flexible scope. This structure. You pass it gently along the floor of the nose and hang it in the throat. And it's connected to a camera and a viewer. So you see the image of the airway as you go in on the screen. And that can give you an idea of what you're dealing with. You may want to do some investigations based on what you find. That can be plain x-rays of the neck and or chest. Like if it's adenoids you're dealing with, you just need a plain x-ray. If it's a tumor, you might need a CT scan. And if it's more of a tumor in a soft tissue like the base of tongue, you probably need an MRI instead. If it's related to maybe swallowing, you may want to do a barium swallow or a modified barium swallow. And you want to check the arterial blood gases just to know how severe the situation is and how to intervene. Do complete blood counts and renal function tests, because these are patients you may be thinking of taking to theater for one reason or other. If you take them to theater, you want to do an endoscopy or an examination under anesthesia. And this is not for all patients who are obstructed, but you are guided by the history and clinical findings and severity of the obstruction and the progression of shortness of breath, if they have eating difficulties, cyanotic episodes, sleep apnea, and the radiological findings. So you are guided before you decide you're going to theater. If you did an X-ray and you found it's adenoids, you probably don't want to go to theater urgently. You'll have to maybe try medical therapy before you decide to offer surgery. You may also want to do a rigid direct laryngoscopy. This is where we use the rigid scopes in theater to look in and perhaps take a biopsy. Like if we had a laryngeal tumor, you want to look at it and take biopsies for examination. So you must actually do a rigid direct laryngoscopy. If you suspect a foreign body, you may want to do a bronchoscopy as well. I mean, a foreign body that has been inhaled. Treatment will depend on the cause that you find. And like I said, it can be medical, it can be surgical, and sometimes you just need a continuous positive airway pressure, like in people who have upper airway obstruction, maybe adults who have structures that are blocking them, or the micrognathia that I was talking about. You may want to start with the CPAP. And then there are those who will require surgical intervention, either to create the airway or to remove the cause of obstruction. Like if it's an abscess, you want to drain it, or a tumor, you want to excise or evacuate a hematoma. So, and sometimes you may want to combine these medical procedures. So because the causes are very many, I'll not go into any particular one unless somebody has an interest in any specific one. So that is all about airway obstruction. Maybe I can take questions on that before I go to tracheostomy. Are there any questions? Class rep, are there any questions posted?
He has raised his hand.
Okay. I'm sharing full screen, so I'm not seeing the hands unless but you can guide that session, yes?
Mike, please unmute and ask the question.
Oh, what the contraindication of, I've seen on the chat, somebody has asked what was the contraindication of indirect laryngoscopy. I said that in epiglottitis, that inflammation of the epiglottis, you do not want to disturb it either with a mirror or even just the tongue depressor, because you touch it, it goes into spasm. And when it does that, the whole airway blocks, and you may not even be able to pass a tube, an endotracheal tube, to intubate. And so there's a risk of losing that patient. So if you suspect it is epiglottitis, we usually diagnose it based on the history, clinical findings, and just a plain X-ray, which would show us the enlarged epiglottis. We don't put in anything, not a tongue depressor, not a mirror, for fear of triggering laryngospasm. Is there another question?
No, there are no questions.
Okay, so we go on to tracheostomy. Now I want to start by just defining two terms which are sometimes used interchangeably depending on where you are. In some countries, you'll find them talking about tracheotomy to mean the same as tracheostomy. But strictly speaking, tracheotomy is making an opening in the trachea. But when this opening is converted into a stoma on the skin surface, then it is called a tracheostomy. So I hope we get the difference there. So this is just a schematic presentation, a representation of tracheostomy, that an opening is made into the trachea. This is the level of the larynx, and that's the trachea. So an opening is made, and this opening is converted into a stoma on the skin, and a tube is put in. That would be now the tracheostomy tube. Sometimes we do permanent tracheostomies where the whole, like in this patient, the larynx was removed because of cancer. And also the stump of the trachea that was left was brought to the surface here and stitched to the skin. So he has a permanent tracheostomy. He has no larynx up here. So this is all he has for breathing. And he doesn't need to wear anything except if it starts stenosing. It's a permanent tracheostomy. So when we talk about types of tracheostomy, it's with regard to timing and the use. You can do an emergency tracheostomy or an elective tracheostomy. Emergency is more in the setting of upper airway obstruction. Elective is when you decide, for example, you're operating on a patient and you think they are going to have a lot of edema, and you decide, I want to put a tracheostomy just to avoid the edema that will come up later, and then you remove that tracheostomy at a later stage when the edema has come down. Then in terms of use, it can be temporary or permanent. Most of the ones we do, we hope should be temporary, but sometimes we treat the condition and find that we are unable to establish a good airway, so they become permanent. And like the patient I've just shown you who had a laryngectomy, that stoma is permanent. I hope you're hearing me. I've just seen a warning that my internet is unstable. Are you hearing me?
Yeah, we can hear you, Doc.
You can hear me, okay. So first we look at indications for tracheostomy. There are 5 main groups, and most examples will fall under this. The most common indication for tracheostomy is for relief of upper airway obstruction, what we have just talked about. And you can quote any of the examples I gave as long as they are higher than the level where you would do a tracheostomy, like tumors in the larynx or trauma in the larynx or upper airway, tumors in the oropharynx. Those are for relief of upper airway obstruction. Then there is tracheobronchial toilet. Sometimes patients get admitted to ICU for long. They have no cough reflex, and they undergo physiotherapy, chest physiotherapy to clear secretions, and they probably have lots and lots of secretions to clear. It gets very difficult to keep suctioning through the endotracheal tube. And so sometimes we are asked to do a tracheostomy so that it makes it easier for the physiotherapy team to clear secretions from the tracheobronchial tree through the tracheostomy. The third main indication is ventilatory support in people like patients who have like a head injury or neuromuscular diseases and cannot breathe on their own, and they need ventilatory support. Yes, they start off with intubation, but like I said, if you keep an ETT in place for a long time, it causes trauma and you end up with a stenosis of the airway at some time later. So if we anticipate that a patient is going to need ventilatory support for long, instead of keeping the endotracheal tube, we do a tracheostomy so that they get their support through the tracheostomy. The fourth major indication is protection of the lower airway. In this situation, we are talking about patients who have a severe aspiration, that whenever they are taking fluids or foods, those foods spill into the airway and go down into the lungs, and the patients are at risk of aspiration pneumonia. So to protect the lower airway, we do a tracheostomy, and there's a cuff, I'll show it to you later, a cuff on the tracheostomy that is inflated to stop materials from trickling down into the lower airway, and that way you protect the airway from aspiration. And then finally, access to airway in head and neck surgeries. Sometimes we do very big operations in the head and neck region. For example, if you are operating on the base of tongue, it can be very difficult to have an endotracheal tube there as you do your operation. So to have clear access, you would do a tracheostomy so that you don't have an endotracheal tube in your way of surgery. So when we are doing a tracheostomy, we position the patient in a supine position. Especially for elective cases, we put a sandbag between the shoulders, and that helps extend the head and make the trachea stick out better and the larynx for easier access. Sometimes when the patients have severe obstruction, they cannot lie down. If they lie down, they feel completely obstructed. So you must find a compromised position, sometimes semi-sitting position. As far as the anesthesia is concerned, in elective cases where intubation is possible, we prefer that the patient is intubated, and then we infiltrate the operative field with a 1% lignocaine adrenaline mixture, 1 in 200,000, or what we commonly call Django Joyce in our setting. But when it's emergency, we only infiltrate the field and do it when the patient is awake. That's an awake tracheostomy. Although even in emergency, if the anesthetist is comfortable to intubate, then we are okay. They intubate and then you go ahead and do your tracheostomy. So this is an extended head. The sandbag is between the shoulders. You clean up the neck, and once you've cleaned properly and draped the patient, if the patient is intubated and we are not in a hurry, we use a transverse incision because this gives a better scar. But if you are in a hurry, when you make this incision inside, you are dissecting by separating things to the side. It wastes your time. So if you are in a severely obstructed patient and time is important for you, you just make a vertical incision because that will allow you to separate the muscles faster and access the trachea. It gives a bad scar, but it will save the life. Once you've opened in, so there are those infrahyoid muscles, the strap muscles that you want to separate, push sideways. This is your carotid on the side. So you made your transverse incision, you are separating the muscles. Once you separate the muscles, you will reach the isthmus of the thyroid gland and the trachea there. But you want to have, to expose your trachea better. So either you can retract this isthmus superiorly or inferiorly before you can, or you can actually split it and tie it up. But we rarely split and tie because that takes quite a bit of time. So you expose your tracheal rings, and when we want to open the trachea, we avoid doing it too close to the cricoid cartilage. Reason being, the cricoid cartilage is the only complete ring in the airway. If you injure it at all, you get airway stenosis as it heals. So we want to go between the second and fourth tracheal rings as we open into the trachea. You can open by just removing the entire tissue, or you can make a U flap like that, or you can make an inverted U flap, or you can do a cruciate incision, like a cross. This is in the adult patient. Yeah, so like I said, you can remove the tracheal tissue, you can do a cruciate, ovoid, or a flap. In children, we do not remove any of the tracheal tissue, we just make a vertical incision. Why? Because the trachea is still small, and if you remove any tracheal tissue, when you have done away with that tracheostomy, you are going to get healing with stenosis, which is going to be a big problem for that child. Then you have your tracheostomy tube. When we are doing the tracheostomy tube for the first time, we use one with a cuff. There's a cuff here, I'm not sure if you can see it, which is inflated through that. This is a double barrel tracheostomy. Sometimes we don't have this component, we just have this introducer inside with the cuff. And sometimes if we have this one, we leave it in. This is very good because when you want to change, you just remove this without having to remove the outer tube. There are other tracheostomy tubes like these ones. They are actually out of use in most places, these metallic ones, and they don't have a cuff because of their type. They are those you'd use much later, not at the time you're doing the tracheostomy. So then once you made your opening in the trachea, you insert that tracheostomy tube in, and then you secure it on the side. When we have just done a tracheostomy, we secure by putting a stitch through this onto the skin. Sorry. We secure it by using stitches. We stitch this to the skin and stitch that to the skin. And our first ties are at the side here. We tie them here. These straps, we tie them on the side. We don't tie them at the back when we have just done a tracheostomy. Much later, you can tie them at the back. Reason for tying them on the side is because most hospital gowns are also tied at the back. So you do not want the patient to accidentally untie it. And if by bad luck, the stitches they are not holding, it falls out and they probably don't know how to return it and you lose the patient. So initially the ties are at the side. So this is an example of a tube, but this one has no cuff. This is much later after you have, several days after the tracheostomy. This patient had a laryngeal tumor that was actually coming out onto the skin. So had to have a tracheostomy there. Now, when the patient is being moved from theater after you have done, they are supposed to be on oxygen. Ideally, we should have this mask, which is a tracheostomy mask. It fits very well on over the tracheostomy in the neck. Most people, okay, in our hospital, we tend to use the face mask onto over the tracheostomy in the neck. But sometimes you'll go to the ward and find that people have forgotten if the patient needs oxygen, they have put the mask on the face, not remembering that the patient is no longer breathing through the nose or mouth. But this is the correct tracheostomy mask to be put over the stomach. And postoperatively, when they go to the ward, if they are adults, you want them nursed in semi-sitting position, just to reduce the edema. And if they are children, because the neck is small, if you make them sit, the chin will cover over the tracheostomy and cause obstruction. So you want them, you roll a small towel and put behind their shoulder so that they are lying on that little towel. The patients who have tracheostomy can no longer speak properly, especially in the immediate postoperative period when the cuff is on, because no air is escaping to go up into the larynx. So they need to communicate. You need to take care of that. If the patient can be able to write, give them a pen and paper so that they write what they are feeling. Later on, I know we teach them how to communicate with a tracheostomy, but in the immediate post-op period, they cannot. So they need to be assisted. If they can't write, then it means maybe they'll just have to use signs. Because you have a foreign body in the trachea, there is a lot of irritation and a lot of mucus being produced in the early periods. So you need to suction that tracheostomy frequently so that it doesn't block with secretions. And then you need to administer humidified air. And you can achieve humidification through like the normal humidifiers, using the bottle on the wall and oxygen. In some places, they use oxygen tents. In other places, we can use a humidifier, but in the immediate post-op period, we don't put a humidifier over the tracheostomy, the commercial humidifier. They need chest physiotherapy to help clear those secretions I have talked about. Now, the cuff, that cuff that we inflated, its pressure on the tracheal wall can actually cause pressure necrosis by its pressure on the little vessels in the mucosa of the trachea and eventually cause stenosis. So sometimes we do recommend that you uncuff that for 15 minutes every 2 hourly. That's if you're not using a low pressure, high volume cuff. There are some special cuffs which are low pressure, high volume. Then you may not need to do this. And then the skin around the stomach, because of the secretions and all that, there'll be a dressing that needs to be changed frequently so that it's not wet and dirty. And sometimes we give antibiotics and analgesia. And we do not attempt to change the tube early postoperatively, because if you try to change, you remove the tube, the muscles flip back, you will not be able to trace where the opening in the trachea is in a patient who is awake. But after about 72 hours, that track has formed. Even when you remove the tube, it doesn't close or collapse back immediately. So one can safely change. But in the earlier days, you just need to suction to keep it clear. Much later, you can change when it is blocked. These are commercial humidifiers, the ones I said you cannot put on the tracheostomy in the immediate post-op period. They have these material sponge-like, which are heat moisture exchangers. So usually you just plug these on top of the tracheostomy. So the air comes in through here, picks the moisture, and so the patient takes in, it picks the moisture and heat, and the patient will be breathing in air that is humidified, and that reduces the crusting of mucus in the trachea. What complications can arise from a tracheostomy? You can have hemorrhage, especially if you, okay, some of the hemorrhage would come from the little vessels around the thyroid. But if you are not very careful and you wander away outside your field, you can even injure the common carotid or the internal jugular vein. Apnea happens because most of the patients who are obstructed are dependent on the CO2 drive. They have high CO2 in their circulation, and that's what drives them to breathe. So you remove the high CO2, then they have no drive, so they actually do not make an effort to breathe. And sometimes you can get apnea. The recommendation sometimes is that you give them air. If you have air, you know, just a mixture of air, not oxygen, in the theater, so that they still have some CO2 going in to make them breathe. You can have the tube displaced or dislodged, especially in the ICU setting where the patients are pushed, you know, turned, being cleaned and all that. It can get displaced from the trachea into the tissues, and that can be disastrous. The tube can obstruct from blood clots or mucus. You could get subcutaneous emphysema. And this happens when, after you've done the tracheostomy, if that incision is big and you try to stitch it and stitch it tightly on the tube, any air escaping around the trachea where your incision is will get into the tissues and cause severe surgical emphysema. If you are doing the tracheostomy in a patient who is awake, sometimes they struggle a bit, they are moving as you do your procedure. You can accidentally injure the lung apex because they are fighting and the apex is pushing up into the neck. You can, in that case, cause pneumothorax. You can get infection in the lungs. You can get tracheitis. You can get crusting in the trachea. When the patient has, when you've sorted out the issue, the reason why the tracheostomy was done, you remove the tracheostomy. You don't just pull it out. It's a process. We call it decannulation. And decannulation can be difficult in some people. Maybe some of them have got used to the tube. So they actually, they fear that if you remove the tube, they will go back into an obstructive state. So they are dependent. You need to handle it better so that decannulation is not difficult. After you've removed the tube, done the decannulation, usually we just leave that opening to close up by itself. But sometimes if the tube has been there for years, there is scar tissue, so that fistula doesn't close and you end up remaining with a fistula. Other fistula that can form a tracheoesophageal fistula, that is from pressure by the tube between the trachea and esophagus. Then you get necrosis of the tissue. Then you can get a tracheoesophageal fistula. You can also get a tracheoarterial fistula because of pressure between the trachea and any of the arteries. This is very serious. Luckily, it's not common. And then, like I said, you can get tracheostenosis after you've removed the tissue in the part of the tracheal tissue, and it heals with scarring. You get stenosis. That is the end. Sorry that we've spilled over because I started a little late, but I can take a few more questions if they're there. Somebody's asking, I explain what is a cuff. And then I repeat the compromise position. Maybe I'll just go back to the picture of the tracheostomy tube. Are you able to see this? Are you able to see this?
Yes, Doc.
Now, even in on the endotracheal tube, have you been to theater or ICU?
Yeah, but I haven't really seen the tubes properly.
Okay, this is a little bag that is connected to this little structure. So usually you push in air using a syringe, and that balloons out. It's like a catheter. If you've seen a catheter, the urinary catheter, you push in a saline and it balloons. So this is what is called a cuff, the cuff of the tracheostomy. This little bag that you balloon. Now I said you balloon it. You can balloon it in after you've done a tracheostomy so that it blocks blood and secretions trickling down into the lower chest beyond your tracheostomy. Or even in patients who have aspiration, that cuff helps you, it stops things trickling down from the upper airway into the lower lungs. Have I made any sense?
Yes, thank you, Doc.
Okay. The other question was, somebody wanted me to talk about the compromise position. Okay, what I said is that we would like the patient to lie down, supine, with the neck extended. But if they are very obstructed, you can't make them lie down. They are so uncomfortable, they cannot. So sometimes you make them sit and do it seated. It's difficult for you as the surgeon, but it is a compromise position. You know, it is what the best you can get under the circumstances, not the ideal. That's what I meant by a compromise position. Let me remind myself the other questions. Any other question? So there's none?
Yeah, there are no more questions, Doc.
Okay, thank you.
Thank you for the class, Doc.